difficult for me to stop it. When I'm round like that, it's much more comfortable, even though it's a stressful sort of test. And I can move it into these positions quite well, without having to bear the weight of the head or anything. And if you're a little bit worried about the compression or whatever, we could put a little traction on, or we could push it down, whichever. I don't usually bother. I just sort of hold the head. And I think that in this position it's so much more efficient than doing it in lying. That's my feelings about this test. And in this position it's a good test. Now, who was it that had got some laxity that we found the other day?
I think I did a little bit.
Yeah. So when we were lying down, it was not possible to feel this, but it was possible to sort of feel this when you came into the positions here, and you look at this movement. There. Okay, I'm holding this very firm. There. As opposed to coming into this one. Nothing. So doing it lying, I don't think that it's particularly, accurate. This is much, much better as a position. So, looking at the board then, the ligamentous tests I think are really important. The sharp purser, the vertebral artery, not the transverse ligament test, of course, we've got to sort of take those into consideration, and then the vertebral artery. Now, what I'd like to do here is to just sort of accept a test that we did the other day of just coming into extension and rotation. You can take it a little bit further if you just wish to be a little bit more careful, but these positions of extreme rotation and extension bear no relationship to the testing positions or to the treatment positions that we're going to use. So I'm not sure that we should be using these extreme positions. But tomorrow, or perhaps in a day or so, when we get back to the vertebral artery, we should try and analyze the vertebral artery in terms of trying to determine where in fact a problem lies, so that it may be possible that if we'd got, for example, a hypermobile joint at C1-2, and this is what we've decided is causing the obliteration of the vertebral artery, and this side now is insufficient to support the circulation, because of course we're always testing it, aren't we, on the ipsilateral side?
Ipsilateral?
Yes.
I thought Paris had said contralateral.
Who is this?
Paris, with his milk tests.
Mm-hmm.
I could be wrong about that.
I'm so glad you asked.
It's ipsilateral in the craniovertebral, but contralateral in the rest of the cervical spine. There. Now everyone's right.
Let me ask you the question. When you turn the head to the left-hand side, which vertebral artery is closed off? The right one. So what are we asking? Is the left one capable of supporting the circulation under these circumstances? So we accept that it's the right one that's being obliterated, but can the opposite one support it under these circumstances? So although it's, so we don't, I don't confuse you with this, although it's the right one that's being obliterated, we're asking, is there sufficient circulation to maintain the circulation to the posterior front? So it's actually the left one that we're asking, can you support this circulation? And we accept that that movement does in most people obliterate the right side.
Do you look at carotid artery at all as far as palpating?
Palpating, yeah. Yes, I used to do that a lot, and chiropractors do this. They look at bruit, they test blood pressure above the arm and somewhere below the arm, so they say. I mean, when I think that they treat a patient in 2 minutes, I wonder if all this goes on. All right, it can't do. But it's been found that most of this doesn't correlate in any way to those patients that had accidents. So it's probably not all that worthwhile. But we used to sort of look at the carotid pulse and see whether it was much smaller on one side than the other. And the reason that this was done was that there was a fairly close correlation between atherosclerotic plaques in the carotid and in the vertebral arteries. But from the stuff that's come out over the last number of years in those that showed that there was some sort of correlation between them, it was so small that I don't know that this is worth doing.
So if you found a big difference between the left and the right carotid, would that contraindicate one motion versus the other?
Only if this caused dizziness, you know, and the signs of immediate nystagmus and all of this kind of thing. Yes, only under those circumstances. I mean, I wouldn't, under any circumstances, do lots of rotary work in this area anyway. I mean, we're just going to do some very little distractive things. But it might, in fact, suggest to you that perhaps manipulation in this case would be contraindicated. And I mean, I don't think this is an area where, probably any area, but certainly this is an area where you take a chance. If you're a bit unsure of what the consequences will be, we've got plenty of other techniques which are as good as, or perhaps even better than manipulating in this area. The mobilizing is very sophisticated, and we do it better than anybody. So, I think we'll just accept a fairly simple vertebral artery test in this particular way, as we did yesterday, because that's what most people do, and then we can do the rather more sophisticated examination. Let's say if Ralph was complaining of dizziness when we went back. If he's complaining of dizziness now, he doesn't get manipulated. But we need to sort of examine that to see whether we can help. And Lewitt has a really good point. He said, what do you do with these people? Say we can't help you, nobody can help you. Supposing they've got blockages, and supposing when we come round with Ralph here, the problem seems to be, because we can start going through these side bend rotation tests, it seems to be that it's at the C12. And that when we look at this, this seems to be hypermobile on this side and stiff on that side. And let's say that we also have 2-3 on this side is stiff. So that over the years, what he's been doing is getting a greater and greater movement at that 1-2. Perhaps it would be a very good idea if we could get in to the 2-3 and mobilize the 2-3 so that the 1-2 doesn't have to rotate as much to give him rotation to the left. Perhaps that's going to be a very important thing that we could do for this guy. So that we could share out the load of rotation over many joints and perhaps try and help the C12 not to have to rotate as far. And I think Lewitt's absolutely right here, that this is a contribution that people that are skilled in manual therapy can do. But of course we'd be thinking probably more of mobilizing this kind of problem than manipulating it, so that if he says, wow, I'm feeling a bit dizzy, we can just immediately come back to the middle and stop. Whereas with manipulation, that's not possible. All right.
In this case, then, would you just do it seated just like that, since you've done everything else so far in the seated position?
If I were looking at variations on the vertebral artery, yeah, I do a lot in this sitting position and coming here. The only problem with sitting is, of course, that the technique's going to be done in lying, and you can get more movement in lying because of the relaxation of the muscles. So I think really, if you've got a patient that was in any way questionable, you would always do it in lying as well. All right, so just make sure that whoever you're working on, there is no problem, and then I'd like to go and have a look at how we're going to manipulate the occipito-atlantal joint.
To screen for craniovertebral to tell if it's C23 or AA or OA, one of the tests we were taught was to rotate the head as far as you can to the right, then put your hands on the atlas and left rotate it, and then do that bilaterally. Do you like that, or do you use that?
This is one of Evian's concepts of provoking or relieving pain. And I think it's okay. Except, well, the problem is that you are increasing pressure over a very tender area, and sometimes just the pure pressure itself is quite aggravating. But what we were talking about here is if I take the head over to the side here and it's rotated this way, then I can come in and I can kind of de-rotate back like this, all right, which means that now if I take hold of the say the C1 on C2 and I push C2 this way, it's still further increasing the rotation to the right at the 1 on 2, but it's decreasing the problem at 2 on 3. So if it decreases it when I do that, I'd be thinking of 2 on 3. But if I got hold of the axis and I pulled it round like that, it's still further increasing the rotation of the atlas on the axis. And so it would signify that it was the C1 on C2 joint. Yes, they're all right to do. They're all right to do. Okay, let's just go to the tables and see what we can do with this. So just do a little test. Was that clear to you?
See,
You're sitting in.
Bill taught us that in Ottawa, and that's how I right rotate them, and I take the atlas and see if it moves, and I. Rotated to the left. But it doesn't mean it's not having done something.
Now, I'd like to just look for a moment or two at the manipulation of the occipito-atlantal joint. And there are probably 2 or 3 things that we can consider here. But the only one that really is like a foundation technique for us is to do a distraction. And when we do a distraction, I'm going to take a contact point behind the mastoid like this, and to save me slipping off the side and coming up here by the ear, which would be somewhat uncomfortable, we've got to create a little side bend of the head. If we create a side bend of the head, we've got to rotate a little, because we've got to give that couple. And if we do that and that together, the axis will stay in its middle position. Now, we're not moving the atlas on the axis, but we still feel that the axis is the sort of key bone in this area, and it would be better for it to stay neutral. And so if we simultaneously do that and that, it achieves the central position of the axis. And also, if we do that and that, we've got a little lever over which to move this joint. Now then, I'm going to engage from the back here a little manipulative thrust, and as I do my thrust, okay, because it's slightly posterior, the chances are that the neck will come a little bit into perhaps a flexion position. Now, I'm not talking about flex like this, but just slightly inclined this way instead of that way. And we've tried to avoid extension because we know there are consequences with extension in this area. So this is a relatively easy conceptualization. It just requires some strength. And so this is not the easiest technique to do. It requires speed and a certain amount of force to actually do it. Now, this is a distraction technique. And what's going to happen if C1 on C2 is hypermobile? The chances are we're going to do that. The only way we could avoid that would be if we could actually take the head like this and get on this and push the atlas away from this. And that's very difficult to do. Although somebody in one of our exams came up and did it on me, and I was most impressed with this technique. I think he was one of Diane's people. Okay, so this was quite good, but it's one of these techniques that you occasionally do and you're pleased with yourself, but it's not a technique that you can do with any great regularity, I've found. So, this is what we shall do. I'm going to show you a couple of positions to do this, but this is going to be the last thing we'll do today, because you're all looking a little faded. And I know that's not how you are. Okay, so I'm just going to feel the mastoid. I'm going to come onto the back of the mastoid with my golden point here. Just take hold of the head like this, a little side bend and rotation. That will be it in that position. Now, because it's a distraction technique, I'm going to be in line with the facet joint here. And I'm just going to come straight the way up here. Now both hands will work at the same time. This is not going to yank around like this. It just goes with it, because I don't want that to happen. Because if that happens, I'd have to rotate it this way, and I can't do that as quick as that. So I want to maintain that relationship and do that movement up in there with both hands. Okay? So I'm just going to take the table up a little bit.
This is a distraction.
This is a distraction of the OA, and it'll be exactly the same technique for the AA. We'll just engage the atlas instead of the occiput. So this will be a very useful technique for both areas. So I'm going to come in around here and just do a little movement like that. So it's all over. We can all go home. All right? The trouble is you can't do these in slow motion. All right, so I just engage and that's it. That's it. Both go together there, but the thrust is there. And this is a technique that you have to be quite strong with, but it's in very safe sort of ranges here. When you consider what John Manell used to do, which was to sort of come around right round here and do this sort of stuff, okay? When you think that what we're doing is putting very little stress on here and we're just coming up into that position. This is a very, very good technique. And if we add this to all the mobilizing procedures, then we've got just an excellent group of things. There's about 28 or 30 techniques around this area that we know. We're the kings. Okay, so let's try this.
Specifically distracting one or the other?
It's distracting the one on the side of the impulse. So it's on the side of the side bend, yes. But it might get C1 too as well. I think it would be appropriate today if for the first 10 minutes we don't ask Dave any questions, just to sort of celebrate his birthday. After that, we'll ask him all the questions. When we're talking about the craniovertebral area, obviously it brings up a lot of challenges for us, no question. Challenges in the sense that it's a tough area. Challenges in the sense that there is the downside in terms of the instabilities that can occur. And we know that as we get kind of more senior in terms of our experience levels, these patients tend to get sent to us for a kind of an opinion. So we have that very, very peculiar thing going on, that the more experienced you become, the worse your results get. And the more frustrating it often becomes. You know, you get a doctor that perhaps rings you, well, I send all the easy cases elsewhere, I'm only sending you the difficult ones. And you think, geez, I'd like to have some of the difficult ones. I don't be suffering every day with going through all of the really hard problems of management. And we had quite a good little discussion in my group on this whole business of the difficult signs and symptoms in this particular area. And what I think we should address, but not today, because I'd like to sort of really get through this area and then perhaps get into the lumbar spine today, so that by the end of the third day there's quite a lot of stuff that's been done practically that we can then keep reviewing each day in the two major areas where we're going to be applying this. And also you've had the time with Diane. Were all of you with Diane, or? I wasn't. Okay. So have to have a quick review at the break time of Diane's work. Okay, and so we can sort of accept that when we get to the end, you'll be all very familiar with a lot of the techniques in the thoracic spine, and that's going to be nice for you because then we can review. Now, I don't know whether the techniques she's doing are exactly the same as mine, and it really doesn't matter anyway. But the principles of the thrusting we'll get to by the last day in the thoracic spine, but I really would like to today get a lot of this stuff with the lumbar spine involved as well. But when we're talking about the craniovertebral area, obviously instability is a very big thing. The vertebral artery related to that instability is a very big thing. And also the whole problem of dizziness. Now, we should look at dizziness as a separate sort of area because this is a symptomatology of patients with problems in the cervical spine and particularly in the craniovertebral area, that there are some times that treatment would be inappropriate. There'd be some times where treatment would be contraindicated, and there would be some times where the best treatment for this dizziness is treatment of the craniovertebral area, and possibly by manipulation. And so it's very important that we eliminate the inappropriate ones, we specially eliminate the contraindicated ones, and we focus in on the vertebrogenic origins of dizziness. Now, in the notes, I've given you an article by Bogduck. It's possibly not the best one I could have given you looking at it just now. It's excellent for its restriction of dizziness from the vertebral artery. And so we should look at that and read it through prior to tomorrow. It's also got a very good, it's in, I think in the section on the craniovertebral area, and it's E18. There's an extremely good diagram there of the sources of dizziness. And I'll go over this in the next 2 days with you on some of the tests like Hautant's test and the modified Romberg's test and this kind of stuff, and to see that we can find those that are vertebrogenic in origin that we can treat. But we'll just leave that for the time being. Now, what I'd like you to do today, because of the importance of this particular area, I'd like you to work with somebody totally new. I'd like you to perhaps just review this particular little algorithm that we did yesterday, this flow chart, and let's just go through this, and Chris and Anne and myself will be within the groups, of course, and if there's any problems with this, just bring them up. And let's try and tackle them and finish them off so that we can then go back into doing some of the mobilizing and of the manipulation in this area. Now remember, by determining the segment, and I'll just talk a little bit about this first, by determining the segment, there's obviously problems of pain without having kind of total blockages of whole ranges of movement. Now, yesterday I gave you the example of loss of side flexion of the skull on the neck. So we don't get too specific. Just the angular movement, that is lost. And we saw that this could be lost if we're talking about left side flexion of the skull on the head. You remember that this could be derived from the OA joint. And to keep everybody happy, okay, a right translation of the occiput would give us a left side flexion of the skull. Next thing that we saw was that you need for this a right rotation of the AA joint, of the atlas moving on the axis, and we need a left rotation of the C2 on C3. And all of those are required to be free to allow us to get this side flexion of the skull on the neck to the left. So what I suggested was, if we got something where it's kind of like this, could we try and break this up a little bit so that we could independently look at these? Now, you've all got different kinds of ways of doing this, and all this kind of course should do is to sort of say, look, here's perhaps another way, and you look at it and you think that's not as good as what I'm doing. That's fine. But it's just a matter of sort of thinking to yourself, well, I've been a bit unhappy with that, and here's another thing. I wonder if that would make it better. That's what this level of course can do, and that's why it's nice to teach, because you don't have to come up with truths all the time. It's just other ways of looking at it. So we could look at, as I suggested yesterday, an analysis of 2-3, because we can make that move independently. And if this is stiff, then the thing to do is to just start treating this. Not worry about what's going on up there, because this is materially going to affect this, and we're never going to be able to bring about anything in this area unless we get this freed up. Now, it could well be that there's still going to be some OA stiffness. It could well be, but we don't know that, because if there's this, we can never get up to that to test it, because this has such a major influence. So as we can treat this, and this is a very, very common source of problems, because the axis seems to be a key bone, doesn't it? It affects what happens above it, and it affects what happens below it. So the axis is very important, and we should probably tackle C2-3, and then when you get to C1-2, apart from flexion and extension, go for the major motion there, you'd have to have a major difficulty in rotation to stop side flexion of the OA joint. Because, you know, to get only a 1 or 2 degrees of rotation here, less than the 10 degrees required to sort of get this movement going, would be an extraordinary loss of rotation. And it would be easy to see that we just couldn't get any movement like this when you did the sort of independent rotational test for the C1-2 joint. So my feeling is that we should always address the C2-3 in the sort of pattern of correction, and then the chances are that we should probably be doing the OA next.
How have you assessed that the problem is at C2-3?
Simply by getting the patient there and doing a coupled movement of side bend and rotation to the same side. That can go on with total fusion above it. So we look at, let's say that this is missing, like this, all right? Now what I do is to take hold of the C2, feel C3, and just have a look at that, just that gentle motion to the right, or in this case to the left, because it's left side bend we're looking at, and just see if that movement is present. If that movement is present, that's a left rotation of C2 on C3 in the presence of side flexion to the left, then I know that that's not what's stopping the motion. Then my next thing would be to go up and have a look at the rotation to the right of the atlas on the axis. So I'm gently feeling the C2 now. I turn the head this way, and if immediately the axis wants to move, I know now that I've gone down to the 2-3 joint again, because I should be able to get that 10 degrees or whatever of independent rotation without having to bring in the side bend, without moving the axis. And that's how I would do it. And I would probably simply do it like this rather than do it in this way, but both of them would be perfectly acceptable.
And you're feeling for motion more than in with the bones.
Yes, just feeling for motion. But I am feeling the bones because I'm